Kita umur kitab Al-Fatihah. Okay, all right. Let me bring my slides up here. So we'll do one by one. I think we'll begin with the adaptation to extrauterine life first, because I think that is the one that is a bit more complicated. I'm a bit unwell, so we'll see how it goes lah. Sorry for all the unwanted sounds. Okay, all right. So we'll this morning we'll begin with the topic of adaptation to extrauterine life. So usually what happens, usually what happens is I like to draw the things, but then I think this morning let's just go with the slides that we have prepared, and then we'll see how things goes lah, inshallah. Okay. So the aim of this topic is basically to make sure that you all understand the changes that take place in the neonatal in the neonate at birth, especially in relation to the fetal circulation, in relation to the fetal circulation, because there's a lot of changes from intrauterine life to extrauterine life. There's a lot of changes that you need to understand, because these are the changes that affect the baby in the short term and also the long term. And you need to understand the adaptive changes that happens to the baby, basically for the baby to adapt to living outside of mother's womb. Okay, the first thing is we'll discuss about the fetal circulation. Okay, if you see here, blood from the mother goes into the placenta. The blood from the baby will then get oxygenated in the placenta. You need to remember, placenta is a highly vascularized structure. It has very low resistance. If you remember your like electric circuit, isn't it? They are the serial circuit, and there's different types of circuit. And when you organize your circuit in a way, it reduces the net total resistance. And if you remember, I think you learned this in your first year. Blood pressure equals, what was the equation for blood pressure? Blood pressure equals apa? What times what? Najwa. Blood pressure equals
total peripheral resistance times with cardiac output.
Cardiac output times TPR. Cardiac output times total resistance. That's blood pressure. How about cardiac output? Cardiac output is
stroke volume times heart rate.
Stroke volume times heart rate. So whatever the resistance actually affects the net blood pressure. And you remember when you calculate it's a total net resistance that results in the blood pressure. Okay. So placenta is a highly vascularized structure, and it's a very low resistance. It is a very low resistance. So oxygenated blood from the placenta goes into the baby through the umbilical vein. So umbilical vein is what carries oxygenated blood. Umbilical vein is what actually carries oxygenated blood. So it goes inside goes into the inferior vena cava through the ductus venosus. So umbilical vein, ductus venosus. Ductus venosus then gets inserted nearby the hepatic veins, and it gets into the right atrium. So in the right atrium, as usual, blood goes into the right ventricle. But you remember there's also a foramen ovale. So foramen ovale is here. Foramen ovale is like a flap. Because it's like a flap. It allows blood to flow from the right ventricle to from the right atrium to the left atrium. It doesn't allow blood from left atrium to go back into the right atrium. There's a flap. The foramen ovale functions like a flap. It is actually a flap. If we do echo after birth, how do we differentiate between atrial septal defect and also foramen ovale? In foramen ovale, there's a flap. We can see there's a flap. It moves, and when it close, it really close. But in atrial septal defect, there's a defect. It doesn't close because ASD doesn't function like a flap. But foramen ovale is actually a flap. So when it is a flap, it allows for a unilateral movement of fluids. So blood can go from the right atrium into the left atrium, but it doesn't allow vice versa. Okay, all right. So majority of the oxygenated blood goes from the right atrium into the left atrium. Some of it goes into the right ventricle, and then it goes to the pulmonary vein. So in the pulmonary vein, it then goes into the systemic circulation in the fetus via the ductus arteriosus. So ductus arteriosus connects between pulmonary vein to the aorta. Ductus arteriosus connects between the pulmonary vein to the aorta. So this blood is then circulated through your body. Why? Because it bypasses the lungs. So usually, extrauterine blood from the right ventricle goes to the pulmonary vein. Pulmonary vein then goes into the lungs, isn't it? But now the lungs are filled with fluids. The lungs are filled with fluids. And when the lungs are filled with fluid, there's high pressure in the lungs. Lungs are filled with fluid. There's no oxygenation process happens. The vessels in the lungs are compressed because of the fluid inside the lungs. So when when the vessels are compressed, there's high pressure. So when there's high pressure, there's not much fluid going through the pulmonary veins into the lungs. So that's why most bloods will bypass the lungs. How? It goes via the foramen ovale, as I've mentioned before, from the right atrium to the left atrium, and also some that goes into the right ventricle will then go into the pulmonary vein, but it bypasses the lung via the ductus arteriosus. Why again? There's several reasons. First, the ductus arteriosus is very patent. That's one thing. Second, because of the high pressures in the lungs. Why the pressures in the lungs are high? Because of the fluid. Fluid compresses on the alveolar and so on and so forth. It compresses the blood vessels inside the lungs. So when there's compression, there's increase in pressure. When there's increase in pressure, it's very difficult for blood from the right ventricle to actually being pumped into the lung. So what happens is majority of it will be bypassed through the ductus arteriosus. So it gets into the aorta, and blood from the aorta, as usual, will be supplying the whole body of the baby. The whole body of the baby as per usual arterial circulation. So from the arterial circulation from the whole body, it goes into the capillaries, goes into the veins, and back into the veins, back into the inferior vena cava, where it will then, near the hepatic vein, will be joined by the oxygen-rich blood from the umbilical vein. And blood from here, how does it get oxygenated back again? It will go in via the umbilical arteries, via the two umbilical arteries. It gets into the placenta back again to get oxygenated back again by the mother. So this happens all the time. And you remember as well, the blood from the mother that goes into the placenta is actually a venous blood. So newborn babies, they don't need very high partial pressure of oxygen. Okay, so several things that happens here. The first one is placenta is a highly vascularized structure with very low resistance. It's ultra low resistance. When the resistance is very low, it reduces the total net peripheral resistance. So it reduces the total net peripheral resistance because it's a low resistance circulation. When you calculate all the resistance in the body, and because the presence of placenta, it actually reduces the total peripheral resistance. So that's for the systemic circulation. But for the pulmonary circulation, as I've mentioned before, the lungs are filled with fluids. The lungs are filled with fluids. The fluids compresses on the alveolar, compresses on the bronchioles, causes vasoconstriction. All this results in a high pressure pulmonary circulation. There's there's pulmonary hypertension, which is normal. So the pulmonary pressure is much higher. The pulmonary pressure is much higher. So this is normal. This is normal. And there is a patterned foramen ovale, which allows blood to pass through from the right atrium into the left atrium. And also there's patterned ductus arteriosus, which allow blood to bypass the lung from the pulmonary vein into the aorta. So this is the ductus arteriosus. This is the ductus arteriosus. So ductus arteriosus and foramen ovale. High, ultra low pressure in the placenta, high pressure in the lungs. So this is normal circulation. And we need the umbilical arteries that supply deoxygenated blood from the baby into the placenta to get oxygen back again. And umbilical vein is the one that carries oxygenated blood from the placenta into the baby via the ductus venosus. Okay, this is the normal circulation. So what happens when the baby is being born? Several things happen. The first one, what happens when the baby is being born? We tie the placenta, we tie the umbilicus, and we cut the umbilicus. So we remove this highly vascularized structure from the total peripheral, total systemic circulation. We remove this ultra low resistance structure from the systemic circulation. So what happens is, in the neck, it actually increases the total peripheral resistance. When you increase the total peripheral resistance, the systemic blood pressure starts to go up. That's one thing. Next, what happens? The baby starts to breathe. And baby starts to breathe. Baby starts to cry. So what happens bila baby cry? Bila kita nak cry, kita kena breathe in dulu kan? What happens when we breathe in? What happens when we inspire? Our diaphragm will contract. Contraction of the diaphragm causes expansion of the chest. Now, expansion of the chest, what is it called? It sucks air from environment into the lungs. Kan? Bila baby keluar, especially when the baby is being born by spontaneous vaginal delivery, kan? Even before baby cries, when the baby is being born by vaginal delivery, there is a compression to the chest. Kan? Keluarkan sempit, there's a compression, there's a mechanical compression to the chest. This mechanical compression pushes fluid from the lungs outside. It pushes fluids from the lungs to go out. Kan? The mechanical compression. So that is why newborn babies who were born by cesarean section, for example, they don't have this mechanical compression of the chest. So they are at risk to get TTN, transient tachypnea of newborn. If we do X-ray of babies with TTN, we'll see that the lungs are filled with fluids. There's fluid in the fissure, there's increased vascular markings, there's upper lobe diversion. So there's fluids in the lungs. Because why? Because there's no mechanical compression to the chest as per babies born by spontaneous vaginal delivery. So the first one is, when the baby is being born, there's mechanical compression that pushes fluid from the lungs outside. That's one thing. Second, we cut the umbilical cord. When we cut the umbilical cord, we remove the systemic circulation from the highly vascularized, ultra low resistant placenta circulation. So the net results there is increase in systemic blood pressure. Increase in systemic blood pressure. So the fluids in the lung, some of it has been expelled because of the mechanical compression. What happens next when the chest expands? When the baby starts to breathe in, starts to inspire, and there's negative pressure on the pleural space. The chest starts to expand, air is being sucked in, and the fluids from the alveolar, from the bronchioles, it will then get sucked inside the interstitium, and it goes into the lymphatics. Yeah, fluid inside the airway will then be sucked in, absorbed in. When the baby starts to inspire, it gets sucked in, get absorbed into the interstitium, and it gets it's removed via the lymphatic drainage. So now the lungs are clear of fluids. There's still going to be some fluids. Our airway cannot be very dry. Our airway cannot be totally dry. There should be some secretion. There should be some fluids. Okay. So, but the majority of the fluids are then being removed from the lungs. How? By two mechanisms I've mentioned before. Right? First is the mechanical compression of the chest when the baby is being born. Second, fluids are being absorbed into the interstitium and gets into the lymphatics and expelled. So now the lungs are, instead of fluid, the lungs are filled with air. So when the lungs are filled with air, several things will happen. First, there'll be no compression to the blood vessels. There'll be no more compression to the pulmonary blood vessels by the fluids inside the lung. So bila dah tak ada compression, it starts to reduce the pressures, reduce the resistance in the pulmonary circulation. So reduce pulmonary pressure, pulmonary resistance because of absence of fluid causing compression. Number one. Number two, when the lungs are filled with air, we are increasing the partial pressure of oxygen inside the lungs. We are increasing the partial pressure of oxygen inside the lungs. And one thing that we know for sure, oxygen is a very potent, oxygen is a very good vasodilator. Oxygen is a good vasodilator. So what happens is there will be vasodilatation in the pulmonary circulation. So two things happen. Number one is reduce in pulmonary resistance because of there's no more fluid inside the lungs causing compression to the blood vessels. Number one. Number two is there's increase in partial pressure of oxygen in the lungs because of it's now being filled with air rather than fluid. And this increase in partial pressure oxygen is a very good vasodilator, causing vasodilatation in the vessels in the pulmonary vasculature. And this vasodilatation reduces the pulmonary resistance. What does it cause? It reduces the pulmonary pressure. So net results of both, systemic BP goes up, systemic blood pressure goes up. Why? As I mentioned before, because we cut the umbilicus, we remove the placenta. So systemic BP goes up. Pulmonary blood pressure goes down. Why pulmonary pressure goes down? Because of two mechanisms I've mentioned before. First one, reduce in pulmonary resistance because of no more compression to the pulmonary vessels. Number one. Number two, because oxygen is a potent vasodilator and vasodilatation reduces further the pulmonary resistance and causes reduce in pulmonary pressure. So now, before this, in fetal circulation is, as you see here, because the systemic BP is low, pulmonary pressure is high, blood cannot go into the lungs because very high resistance. So blood is shunted from the left side. Blood is shunted from the lungs via the ductus arteriosus. Kan? Sebab daripada pulmonary vein, dia tak boleh nak pergi ke lung sebab high pressure dekat lung. So dia bypass, dia pergi ke aorta through the ductus arteriosus and go into the aorta. Blood also bypasses through the foramen ovale because of high pressure in the lungs. Now, because the lungs are low pressure, so right side pulmonary circulation, right side is low pressure, left side is high pressure. So in fetal circulation, right side, pulmonary circulation, pulmonary circulation is right side. Right side is high pressure, left side systemic is low pressure. This in fetal circulation. After being born, because of all the changes, we can see now the left side has high pressure and the right side, which is the pulmonary circulation, has lower pressure. So when the left has higher pressure compared to the right, what happens? Blood cannot pass through from the foramen ovale. Why? Because now there is left has higher pressure from the right, and foramen ovale acts as a valve. It's like a flap, so it cannot. It opens only one way. It opens only one way. So foramen ovale starts to close. Number one. Number two, there will be reduced in blood flowing to the ductus arteriosus. Also, oxygen oxygen causes vasodilation in the lungs, but oxygen causes smooth muscle vasoconstriction in the ductus arteriosus. Smooth muscle vasoconstriction in the ductus arteriosus. So ductus arteriosus, the smooth muscle in the ductus arteriosus will start to constrict, will start to spasm, and causing restriction in the flow in the ductus arteriosus. Also the role of prostaglandin and so on and so forth. So when that's reduced in prostaglandin, the effect is the smooth muscle in the ductus arteriosus starts to contract and causing closure of the ductus arteriosus. So when there's closure of the ductus arteriosus, we get the usual circulation that we have after being born. Okay. Faham tak setakat ni? Clear? Clear ke tak clear?
Clear.
Yeah. Okay, again, as mentioned before, the placenta is the organ of respiration. It replaces the function of the lungs. The baby gets oxygenation, or gaseous exchange in a newborn baby happens in the placenta. Oh, well, is a fetus breathing? Fetus ada breathing tak? In utero. Anyone has any idea? Husna. Fetus breathe tak in utero? Tak. Actually, fetus breathe. That's why if you do biophysical, if you do detailed scan, if you do antenatal biophysical profile scan on the baby, we see that the baby should actually start breathing. They should be able to count the respiratory rates. So usually fetus breathes around 12 breaths per minute, usually lebih kurang. So they do breathe, but when they breathe, there's no gas. The baby only breathes air. The baby only breathes fluid, amniotic fluid. That's why amniotic fluid gas into the lungs. So the baby fetus does breathe in utero, but there's no gaseous exchange. There's only more fluid that goes in. So placenta is the one that functions as the lungs, and umbilical vein is the one that carries oxygenated blood. Whatever vessel that goes into the heart is called a vein. Whatever vessel that goes away from the heart is called an artery. So, and because of the pressures, as I mentioned before, there is right to left direction. Why right to left direction? Because right side, which is the pulmonary circulation, has higher pressure as compared to the left side, which is the lower circulation, lower pressure circulation. There's two places where they bypass, where the first one is the ductus arteriosus and foramen ovale. So as mentioned before, there's several mechanisms why the pressure is high, because there's fluid in the alveoli causing pressure, and also the vessels, the pulmonary vessels are constricted. Pulmonary vessels are constricted. So this is the ductus arteriosus, where the fluids from the right ventricle, it goes to the pulmonary vein. It goes to the pulmonary vein and it bypasses the lungs. It goes straight into the. Why it cannot go into the lungs? Because the high pressure in the lungs. So it bypasses and goes into the aorta through the ductus arteriosus. So when we cut the umbilical cord, all these biochemical changes happen, and this results in more changes. The baby starts to breathe more. If you remember our carotid body and also the aortic body detects high CO2, low pH, and this results in activation of your cardiorespiratory center in your pons. So the cardiorespiratory center starts to fire up and stimulates the baby to starts to breathe more. And mechanical, as mentioned before, there's compression, mechanical compression during vaginal delivery, and when the baby inspires, it reduces the intrathoracic pressure. It sucks air from environment into the chest. So as mentioned before, so fluids in alveoli, when the baby takes the first breath, fluids will then get absorbed into the interstitium, and it will then be excreted via the lymphatics. So for an effective respiratory function, there should be adequate pulmonary blood flow. There should be adequate amount of surfactant. So surfactant is the one that maintains the integrity of the alveoli. It keeps the alveoli open because it affects the surface tension. So without surfactant, the airway will collapse. Without surfactant, the airway will collapse. So this is what happens to premature babies. The airway starts to collapse. There will be hyaline membrane disease, or what we call as respiratory distress syndrome, because the deficient in the surfactant. So surfactant starts to be produced by newborn babies usually around 34 weeks. So we have more surfactant by around 34 weeks. Less than 34 weeks, we don't have that much surfactant. So we need to replace the surfactant. Also, there are other diseases that cause problem to surfactant. For example, in babies, in infants of diabetic mother. So infants of diabetic mother also has reduced surfactant. Also in babies with meconium aspiration, because meconium counteracts the surfactant. Meconium causes deactivation of the surfactant. So it can cause respiratory distress syndrome as well. Also in more premature babies, the respiratory muscles, the diaphragm, the intercostal muscles, they are not strong enough to support the normal and usual respiration. Sorry. So after birth, previously as mentioned before, the primary organ of respiration is the placenta. Now after birth, we remove the placenta, and the lungs are now the primary organs of respiration. The lungs is where oxygenation happens. The lungs are where the oxygenation happens. So blood vessels in the lungs respond to the oxygen, so it starts to dilate. So reduced pulmonary pressure promotes blood flow into the lungs. So if you understand this, what happens when the blood pressure in the lungs remains elevated? What happens? As I said before, sepatutnya what happens, because of the changes that I've mentioned, reduces the pulmonary blood pressure and increases the systemic blood pressure. So my question is, what happens if for some reason the pulmonary blood pressure remains high? What will happen? What can happen?
TPN?
Huh?
TPN, Doctor.
TTN?
TPN.
Not really. TPN. What is TPN?
So sorry. Transient pulmonary hypertension.
Pulmonary hypertension. So PPHN, persistent pulmonary hypertension of newborn. Persistent pulmonary hypertension of newborn, which is a very complicated and very problematic punya disease. So what happens is the pulmonary blood pressure remains high. Why? Because of persistent pulmonary vasoconstriction, because of the ductus arteriosus remain open. So when the pulmonary pressure remains high, there will be persistence of the right to left shunt. There is persistence of the right to left shunt. Why? Sebab the right side, the pulmonary pressure remains high. So that is why when there is persistent pulmonary hypertension of newborn, if you check the SpO2, if you check the oxygenation level pre-ductal, before the ductus arteriosus, you know, if you remember your ductus arteriosus, kan ductus arteriosus, it supplies the vessels, kan, brachiocephalic, so it's the aorta. So now oxygenated blood, if there is persistent pulmonary hypertension of newborn, kan, blood from here, this supplies the right hand and also the right carotid artery here, brachiocephalic. Is a brachiocephalic artery, kan? So this supplies the right brachial artery and also the right carotid artery. Yes, right brachiocephalic artery. So it supplies these two. So if you measure the SpO2 on your right upper limb and also right side, like even like the ear pinna and so forth, you'll get high SpO2. Why? Because this is oxygenated blood. But now, because of the persistent pulmonary hypertension, deoxygenated blood from the right ventricle goes into the pulmonary vein. And because of the high pulmonary hypertension, what happens is blood then goes into the ductus arteriosus. So that is why the post-ductal SpO2, so this one, the carotid artery, the brachial artery on the left side and other parts of body, you'll get the SpO2 to be low. There'll be post-ductal discrepancy. You measure SpO2 on the right upper limb, it will be more than 90. You measure the SpO2 on the post-ductal on other limbs, you'll get the saturation to be very, very low. So this is what we call as post-ductal discrepancy. Why? Because the ducts, usually the ductus arteriosus usually is after the brachiocephalic artery. So that's when there's post-ductal discrepancy, that's what we get. Okay, faham tak? Okay, alright. So this is another view lah. So the two pulmonary arteries from the aorta. This is yeah, okay, fine. We've gone there. So I've mentioned before what happens in the pulmonary and systemic circulation, difference in the blood pressure. We've cut the umbilical vein, umbilical arteries, so we remove the low resistant circulation. Ductus venosus starts to close, and because there's no supply to the umbilical vein, and then the ductus arteriosus starts to close as well because of oxygen, because of the prostaglandin effect, and also foramen ovale also starts to close. So these are the among the changes. Next is the thermoregulatory changes. So when the baby is being born, so in utero, babies are in a very comfortable environment. Fi qararin makin, Allah mentioned, Allah created human being in a fi qararin makin, in a place that is very comfortable, very secure. So it's protected by the mother. It's inside a cushion of amniotic fluid. The thermal environment is protected, is maintained by the mother. So for optimal growth, for optimal metabolism, babies need a constant and proper temperature. But now, after being born, baby needs to maintain the heat by themselves. They need to maintain the temperature by themselves. So what can they do? The first, and then you need to remember, in a newborn baby, especially more premature babies, their thermoregulatory center in the brain, in the pons, is not mature enough. In the hypothalamus, the thermoregulatory center in the hypothalamus is not mature enough. So that's why newborn babies, they cannot control their own body temperature. You as adults can, when we are cold, our body, when it's hot, our body will do things to actually reduce the temperature. We sweat, the effects of our hair and so on and so forth. But newborn babies, the thermoregulatory center is still immature. They cannot maintain, they cannot regulate their own body temperature. It's very difficult for them. As among the factors that affects thermal that maintain heat in the baby are the brown fat. More brown fat helps the baby to maintain more heat. But more premature babies, they have less brown fat. More premature baby, they have less brown fat. So when they have less brown fat, they cannot maintain their temperature really well. So that is why it's very important for us to help the baby to maintain their temperature. So if you see babies kan, newborn babies, kalau you balut banyak-banyak, when you check the temperature, it will go up. When you remove all the wrappings, they'll get low temperature. So we need to help the baby to maintain the thermoregulation. So how heat is conducted, how heat is lost, how heat is gained, basically there are several mechanisms. The first one is conduction. So conduction ni maknanya direct contact. Direct conduction of heat. Direct conduction of heat from contact surfaces. B is convection. So convection is movement of fluid, movement of air, flow of things. So the flow, the movement actually reduces the heat. The heat is lost by that mechanism. Number three is evaporation. So where you have fluid droplets on your body, it changes from fluid into vapor. So this process of evaporation actually loses heat. And last is radiation. So radiation is by so basically radiation is contactless type of heat transfer. Contactless type of heat transfer. It's like when you introduce a heat source from above. So the heat will be dissipated by radiation without air movement. So that is what we call as radiation. So that's why the heater that we have in NSU, that is called a radiant warmer. It's called a radiant warmer. If you switch on the fan, for example, what type of heat transfer is the fan?
Convection.
Convection, yes. Convection. If any one of you have been to countries like UK, cold climate countries, you have a warmer inside the house, you have a heater inside the house. So that is transferred by radiation, because there's no, unless if you have a fan that moves the hot air. This is very important if you understand things like tepid sponging. So for children kan, you see people selalu buat tepid sponging kan. What do you understand by tepid sponging? Biasa orang buat macam mana dalam buat? Biasa macam mana orang buat tepid sponging?
Tepek-tepek, basahkan betul lap.
Okay, selalunya what I see people do, and sometimes dia ambil cold towel kan, dia letak dekat dahi lah, dia letak dekat ketiak. So what happens is initially there is heat transfer by conduction. There'll be heat transfer by conduction. So cold punya towel is in contact with the skin, then there'll be heat transfer. But there's several problems with that. The first one is the towel will now become warmer and warmer and warmer. That's one thing. So when it becomes continuously warmer, there'll be less conduction. Nombor satu. Nombor dua, when you introduce a cold punya material to the skin, there'll be the vessels on the skin will start to vasoconstrict. The vessels in the skin will start to vasoconstrict. So what happens? What happens now? Bila superficial vessel become vasoconstricted, the skin will become cold sebab ada vasoconstriction. But heat, internal heat will now not dissipate out. And internal heat will be conserved because peripheral vasoconstriction. When you touch the skin felt really cold. Why? Because of vasoconstriction. But internal temperature remains high because internal heat is not dissipated out. Sebab macam mana nak keluar? Dah ada vasoconstriction. So if you leave cold towel on the skin, it will actually conserve heat. Especially kalau sampai baby tu start to shiver. Kalau budak-budak tu start to shiver kan, dia start to ketar-ketar. What happens is shivering, muscle movement uses ATP and so on and so forth, and the result is heat. The result of usage of ATP is actually heat. So you'll produce more heat and causes more heat. So but what we want is evaporation. So usually using tepid temperature wet towels yang lukewarm type of water, we just dab on the skin, whole body. Dab, ada some droplets of water on the skin, and when these droplets evaporate, change from water droplets into vapor, this is how the baby should actually lose heat. So that's how we properly do tepid sponging. Okay. Next is glucose. Glucose is another problem. As you remember, in utero, babies get glucose from the mother. Babies get glucose from the mother. But now, after being born, baby needs to get glucose from somewhere else, from feeding and so on and so forth. So if the baby doesn't have enough glucose through feeding, what happens? There'll be not enough glucose. And when the baby doesn't have enough glucose, glucose is the fuel for everything in our body. So there need to be gluconeogenesis. The problem is, does the baby have enough materials for gluconeogenesis? Does the baby have enough glycogen? So that's where the problem lies. So the more premature baby, they don't have enough glycogen storage. The liver is still immature. The gluconeogenesis process is still immature in newborn babies. So they need to have adequate glucose supplementation. So that's one thing you need to remember. Another element is, okay, for example, if a mother is known to be diabetic, for example, kan, what happens in a diabetic mother? What happens? Usually apa jadi? Usually when the mother eats something, kan, bila kita makan benda, our glucose level starts to shoot up, kan, and then our insulin, our pancreas starts to produce insulin. Insulin level rises. Bila insulin level rises, usually within the first hour after postprandial, after we eat, our glucose level will drop down, and there will be a period of relative hypoglycemia in our body. And so this period, that's why within the first hour after postprandial, kita jadi sleepy. Sebab apa? Sebab the relative hypoglycemia. And then it starts to normalize back again. Okay. Now, glucose is a smaller particle. Glucose from the mother crosses the placenta into the fetus. But insulin is a big molecule. Insulin does not cross placenta into the baby. So in a diabetic mother, the sugar level in the mother has always been high. At rest pun dah tinggi. And then bila mak makan, glucose shoots up. Glucose level shoots up. Mother, if the mother can produce insulin, mother will produce insulin to try and maintain mother's blood sugar. But mother's insulin does not cross into the baby. So what happens? How can the baby respond? Baby needs to produce its own insulin. Baby needs to produce its own insulin. The problem is, before 8 weeks period of gestation, baby's pancreas are not functioning yet. Fetus punya pancreas is not functioning yet. So prior to 8 weeks period of gestation, there will be unopposed hyperglycemia. Before the fetus's pancreas starts to function at around 8 weeks period of gestation, there is unopposed hyperglycemia. Mak makan, mak punya glucose shoot up. Mak produce insulin. Mak makan, mak punya glucose shoot up. This glucose also is shared with the baby. Now, mother starts to produce insulin untuk maintain the blood sugar, but baby cannot produce insulin. Baby doesn't get insulin from mother. So there will be unopposed hyperglycemia. And this unopposed hyperglycemia is teratogenic. That is why infant of diabetic mother, especially the non-poorly controlled diabetics, kan, sometimes there will be lots of teratogenic effect. There will be sacral agenesis, spina bifida, AVSD, all the changes actually is because of unopposed hyperglycemia, which is teratogenic. And sometimes people, bila dia tahu dia pregnant, usually around 2 months, usually around 6 to 8 weeks, baru dia tahu dia pregnant. So before that, usually very difficult to get mothers to actually control their blood sugar really well. Okay, now beyond 8 weeks period of gestation, mak ada diabetic, mak has high sugar, kan? Mak produce insulin. Now after 8 weeks, baby punya pancreas pun dah biasa produce high levels of insulin. Sebab mak baby tu in utero dapat sugar high daripada mother. So pancreas dia dah biasa excrete high amounts of insulin. Now, sekarang baby is being born. Kita cut the placenta. Kita cut the umbilicus. Baby is not getting high levels of sugar from mother anymore. But the pancreas has been used to excreting high levels of insulin. So this is what we call as hyperinsulinism. Because the pancreas is so used to producing high levels of insulin. Before, okay lah, insulin high sebab sugar pun high daripada mother. Sekarang tak dapat dah sugar daripada mother. Kan, baby dapat sugar daripada feeding. And feeding kadang volume dia sama je. 60 ml per kilo per day, day 1. 90 ml per kilo per day, day 2. 120 ml per kilo per day, day 3. 150 to 200 ml per kilo per day, day 4 and so on so forth. Kan, so amount dia dapat sama banyak. Kan, tapi pancreas dah biasa produce high insulin. So what happens is, they are at risk of getting hypoglycemia. Why? Because of the hyperinsulinism. So this is what we have in infants of diabetic mother. When you go to NICU, look for all these big babies yang 4 kilo lebih apa semua. Kan, infant of diabetic mothers. What we monitor? We monitor the neonatal blood sugar. Because apa? Sebab they are at risk of hypoglycemia. Kenapa dapat hypoglycemia? Because of hyperinsulinism. Okay, faham tak? Hal fahimtum kalami? Faham ke tak faham?
Faham.
Okay, alright. So, okay, lepas ni semua dah tak berapa important sangat lah. Lepas ni sikit-sikit je. So, fluid balance changes. So, before ada interplay between the urine, amniotic fluid dengan lung fluid, dia nak protect dan maintain growth. Amniotic fluid, presence of fluid inside the lungs, kan? Kita dengar tadi macam problem kan sebab dia cause high pressure in the lung. Actually, selain daripada it is very important to have the fluids inside the lungs. Presence of high pressure in the lungs in fetal life is actually important. For example, if we have a baby with if we have a fetus with diaphragmatic hernia. Apa diaphragmatic hernia ni? Dia ada hernia, ada lubang dekat dia punya diaphragm. Kan? What happens bila ada lubang kat diaphragm? The gastric content, the bowel content, the GI content, the abdominal content can get into the thoracic cavity by the defect in the diaphragm. Itu diaphragmatic hernia. So in babies with diaphragmatic hernia, for example, abdominal content gets into the thoracic cavity, compresses the lungs. Kan? Bila dia compresses the lungs, lung will not be developing well. Dia tak grow well. So what happens? Sekarang ni ada banyak study. When I was in UK, I was part of the team juga lah. We look at it. There's a treatment what we call as phyto. So phyto ni is dia at around 12-week period of gestation, dia akan buat phytomaternal specialist ni, dia akan intubate the fetus, dia letak satu balloon dekat dia punya trachea. Dia letak balloon dekat dia punya trachea. So why? So dia letak balloon dekat trachea ni is to maintain high pulmonary pressure, high pressures in the airway. Supaya fluid dalam airway ni tak keluar. So bila dia buat macam tu, abdominal content susah nak masuk dalam dia punya thoracic cavity, nombor satu. Nombor dua, with high pressure in the lung actually promotes lung growth, pulmonary tissue growth. So that's very important. And then next is the changes in the hepatic system, the liver function. So in utero, baby gets all the nutrients from the mother. But ex utero, baby needs to have its own metabolism. It needs to utilize its own iron storage. It needs to, so the liver must be functioning. The liver must have enough iron storage to actually supply and help the baby to actually produce hemoglobin and so on and so forth. Carbohydrate metabolism, gluconeogenesis, and so on and so forth. Blood coagulation. So in babies, they don't have enough vitamin K, for example, because vitamin K is not present in breast milk. So how do they get vitamin K? We need to supplement them with vitamin K. That's why after birth we give vitamin K. Right? We give vitamin K. If we don't give vitamin K, the problem is it affects the coagulation. So they can have the hemorrhagic disease of newborn. And then liver also is the function is for conjugation of bilirubin. If the liver is not functioning well, there'll be a problem in conjugation of bilirubin. Okay, I think yes. So newborn babies, the stomach is very small. So when the stomach is very small, they can only ingest, they can only take only small amounts of fluid at one time. And then because the sphincter, the muscle are all not strong enough, sometimes they are at risk of getting reflux and so on and so forth. So that's why it's very important to overfeeding is a problem. You know why? Because for newborn babies, sucking and swallowing is a reflex. Kita kalau masuk benda dalam mulut kita tak suck everything. In newborn babies, sucking is one of the primitive reflexes. You put anything inside the mouth, the baby will suck. Sucking is a primitive reflex. So as long as we put something in the mouth, the baby will suck. So how do we know? How do we make sure that there's no overfeeding? So that's where the risk of overfeeding is. Sebab mak dia letak botol ke apa ke, baby will always suck. Not because the baby is hungry, but because sucking is a primitive reflex. So mother should know the cues. Macam mana apa, what are the signs that the baby is already full. The baby is content, the baby starts to release the nipple, kan? The baby starts to sleep, kan? Kadang ada mak baby menyusu, dia nampak baby tidur, dia kejut baby, suruh baby minum. Kan? Sometimes baby sleeping is actually a sign that the baby is already full, kan? And then you nak make sure the baby is kena burping of the baby is very important to reduce the risk of regurgitation and reflux. Within the first 24 hours, baby should pass meconium. Failure to pass meconium in the first 24 hours may be a sign that there's a problem with the bowel. So baby need to pass meconium within the first 24 hours of life. Baby should not pass meconium before birth. Passage of meconium before birth is a sign that the baby is stressed. The baby is in distress. It's a call for help. So baby should not pass meconium. So meconium is toxic. Meconium is toxic to the lungs. Meconium is toxic to many parts. So kidney as well is a problem. So usually sometimes newborn baby, they don't pass urine for the first 24 hours of life. They go initially at birth, they are oliguric, and then they go to polyuric before it normalizes. So the first 24 hours of life, usually they are oliguric, and then they go briefly to polyuric, and then they normalize. And the GFR is also reduced. GFR, glomerular filtration rate, in newborn babies are reduced because the kidneys are still immature. So that is why certain nephrotoxic certain drugs that are excreted by the kidneys, you need to use different dose. Gentamicin, for example, in newborn babies, the dosage is different. So you need to know when you give any drugs to the baby, where are they metabolized in the liver? Are they excreted in the kidney? Where do they affect? The dosage. So dosage usually is a bit different. Vancomycin, for example, vancomycin is excreted by the kidney. So in newborn babies, in extreme premature babies, the dosage is different. Sometimes we use dosages of daily. In slightly premature baby, we use BD dosing. In term babies, we use TDS dosing. So dosing differs because of the kidney function, because of the GFR. So more premature baby, the more low the GFR. So we need to adjust the dosage of medication according to the kidney function. Immune system is a problem as well, because newborn babies, they get, where do newborn babies get their immune system? They don't produce, their immune system is still immature, their immune system is not strong enough, they don't produce adequate amount of antibody and so on and so forth. So how do they get antibody? Macam mana?
Breast milk.
Natural passive.
So there's two. So one is to breast milk. What type of immunoglobulin from breast milk?
IgA.
IgA, so secretory IgA from mother. So that's why breastfeeding is very important, because they get secretory IgA from the mother. That's one thing. Secondly is because it is they get through the in utero transfer, transplacental transfer of immunoglobulin. So IgG generally can cross placenta. IgG can cross placenta. IgM, I hope you remember lah, when is IgM, IgG, IgE, IgA apa semua. So IgG generally crosses placenta. IgM is a bigger particle, so generally IgM does not cross placenta. Some IgM cross placenta, such as dengue IgM, varicella IgM, they do cross placenta. But generally IgM do not cross placenta. IgG crosses placenta. But IgG crosses placenta at around 20 to 22 weeks period of gestation. Before 22 weeks, usually IgG do not cross placenta. So if a baby is being born very premature, they don't have enough number of IgG transfer from mother. So they are more at risk of having infection, having severe infection because of the immune. They don't have enough IgG. And then the skin of the baby, they don't have, their skin are usually more fragile, so they don't have strong mucous membrane, so they are at risk of getting infection. Okay, I think that's it lah. I think that's it. Any question? Any question? So I think the most important part of this presentation is actually understanding the cardiorespiratory changes. How the difference in the systemic and pulmonary pressures changes from in-uterine to extrauterine life. That's the most important part of this lecture. Okay, any question? Ada soalan? Tak ada. Peher belaka ke tidur belaka ni?
Doctor,
Yes.
I want to ask about, you mentioned about the postductal discrepancy, right?
Yep.
So Actually, how do we calculate the preductal SpO2? Is there any?
We don't calculate SpO2. SpO2 is measured. Measure and calculate is different lah. So measure is you put and you measure. You put the SpO2 probe kan. So when there's postductal discrepancy, maknanya you put SpO2 probe on the preductal. So preductal mana? Right upper limb. Right upper limb. Right upper limb is preductal. Before the these are the limbs supplied by the brachiocephalic artery before the ductus arteriosus. Kan? Generally right upper limb, and you can use lah the right ear pinna actually. So these are the supplied by the artery before the ductus arteriosus. Postductal are the limbs after the ductus arteriosus. So all the both feet, both lower limb and the left upper limb. So these are the postductal punya areas. So if you put SpO2 probes on pre and postductal, so if you go to NICU, you see babies with PPHN, you'll see we have at least 2 SpO2 monitors. Satu dekat preductal, satu postductal. We'll see that there is a 10% difference. There's a 10%, so significant is 10%. Less than 10%, sometimes dia ada error machine lah apa semua. So significant postductal discrepancy is 10%. 10% difference. So preductal SpO2 100%, postductal SpO2 90%. That's 10% discrepancy. Macam itulah contohnya. So when there is postductal discrepancy, so that is actually PPHN, persistent pulmonary hypertension of newborn. PPHN can be caused by many things. It can be primary PPHN. Maknanya there's no reason. It's just that the pulmonary vasculature refuses to dilate, refuses to open. So there's persistent pulmonary hypertension of newborn, such as seen in babies with Down syndrome. So Down syndrome is a known cause for primary PPHN. There are other causes of PPHN, such as hypoxia, babies who are hypoxic. Again, as I mentioned before, oxygen is a very good vasodilator. So if a baby is hypoxic, there's a risk of PPHN. Macam mana baby hypoxic? HIE, perinatal asphyxia, or inadequate ventilation. Baby tu dah poor SpO2, tak ada orang monitor, biar je masuk dekat SCN, masuk kat ward mana-mana, no one did anything. For example lah, kan? So baby is hypoxic and results PPHN. Baby's a congenital pneumonia is a known factor for PPHN. RDS is a known factor for PPHN. Meconium aspiration syndrome is a known factor for PPHN. Also, there's a lot of factors that can cause PPHN as well. Okay, clear. Any other question?
Doktor, nak tanya. I'd like to ask about baby's pancreatic function and also hyperinsulinism.
Yep.
So after birth, the baby took several period lah to the pancreas for function. However, how can still the patient, the baby develop hyperinsulinism?
Tak faham soalan ni.
Sebab pancreas kan dia develop ambil masa untuk develop and function ni doktor kan. Tapi kalau
Taklah, pancreas starts to function 8 weeks period of gestation, dalam perut lagi.
Oh, 8 weeks gestation.
Masa fetus tu umur 8 weeks. Masa 6 to 8 weeks kan banyak organs starts to form. Our heart is formed around 6 to 8 weeks. Kan? Betul lah, before 6 weeks kan tak ada apa sangat, tubing-tubing je. Kan? So around 8 weeks period of gestation, our pancreas starts to function. It starts to excrete insulin around 8 weeks period of gestation. Dalam perut. Umur 8 minggu. So at birth, sebab pancreas dia dah biasa bekerja keras, so that's why dia dapat hyperinsulinism. And you need to remember, insulin functions like a growth factor. Insulin like growth factor. So insulin functions like a growth factor. So that is why babies who infant of diabetic mother with high levels of insulin, they'll be macrosomic. Dia akan jadi besar. Sebab insulin. dia boleh dapat cardiomegaly sebab insulin, especially the intraventricular septum. Dia punya IVS dia besar. Sebab apa? Sebab the insulin-like growth factor, and this can result in hypertrophic obstructive cardiomyopathy. Also, because of the high levels of insulin, it functions like a growth factor. The placenta can be big as well, and the placenta is big. And sometimes bila placenta they too big, sometimes baby may be too small. There can be element of placenta insufficiency and so on and so forth.
Okay,
Okay.
Doktor.
Any other question? Okay lah. I think that's it for today. We'll see you guys tomorrow for the other part of the lecture, prematurity and its complication. But we'll see how things are. I'm a bit unwell. We'll see if we can proceed. Like if I think if I'm not well enough to do, then probably we just have to postpone to another time. But we'll see. Like again, sorry for the so many rescheduling of things. There's just no option. Okay, all right. I think that's it. Let's end our session with tasbih kafarah and surah al-Asr. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh, and
Thank you,
insyaAllah
Doktor.
get well soon. Doktor.
Assalamualaikum.
Thank you, Doktor. Salam.
Okay, Doktor.